Okay, hi everyone. Welcome to the Epidemiology Seminar Series. I'm Angela Lee Nguyen, an assistant professor in Department of Epidemiology at Colorado School of Public Health. Today we have today's seminar is co-hosted with PIPER, which stands for the Program for Injury Prevention, Education, and Research. And today we have Dr. Ingrid Binswanger and Ms. Lisa Rayville as our speakers. We're truly excited to have them give us their talk on overdose prevention and harm reduction, research to practice. Dr. Binswanger is a senior coalition investigator at the Institute for Health Research, Kaiser Permanente, Colorado, and an assistant professor in the Division of General Internal Medicine at the University of Colorado School of Medicine. Her research focuses on reducing overdose and HIV as the medical complications of substance use and reducing the morbidity and mortality of people with histories of criminal justice involvement. Ms. Rayville is the executive director of the Harm Reduction Action Center, a public health agency that works with people who inject drugs. Lisa has been with HRAC since 2009. She's the co-chair of the naloxone work group for the Colorado Consortium on Prescription Drug Abuse Prevention, and also the vice president of the board of directors of the Colorado Criminal Justice Reform Coalition. She received the Colorado Public Health Association Award for Excellence in Policy in 2014. So today's seminar will be recorded and posted. Please put your questions in the chat box. We'll monitor the chat box and read the questions when we receive during the Q&A. Dr. Amy Betts, an associate professor in the Department of Emergency Medicine at the University of Colorado School of Medicine and the deputy director of PIPER, will lead the Q&A session. So without further ado, please welcome Dr. Binswanger and Director Rayville.
Great, thank you so much. Let me know if I can, is the audio in the presentation up? Yes, okay, good. Okay, so I'm going to talk a little bit, I know Lisa is going to talk a lot about harm reduction in the community and with people who inject drugs, and I'm going to talk a little bit about harm reduction and how it's relevant to opioid management for chronic pain and healthcare settings. I really don't have any disclosures. I just want to acknowledge the CDC and NIDA for the funding for some of this work. So the objectives for this presentation are really to examine both the benefits and the potential harms of opioid dose variability, which is a concept that I'm going to define shortly, and also opioid discontinuation or stopping chronic opioid therapy in the setting of patients who are treated with chronic pain. And then I'm going to think about a framework for thinking about how harm reduction principles apply to healthcare settings and chronic opioid therapy, and how we can use what we've learned in community-based settings and from harm reduction agencies like Lisa runs to help our patients in practice. So I think we all know that there have been, let's see here, I don't know. Okay. I think we all know that there have been a number of studies that suggest that very high doses of opioids or even moderate doses of opioids are associated with increased risk for opioid overdose, particularly pharmaceutical opioid overdoses. And in response to some of these observational studies, the CDC issued some important guidelines in 2016 that encouraged providers to assess both the benefits and the harm of ongoing treatment of opioids for chronic pain and also of initiating opioids. And they recommended at the time actually a very balanced recommendation to consider, for physicians to consider reducing the dose and or discontinuing opioid therapy if the harms of opioids outweigh the benefit. Unfortunately, that didn't come along with a lot of guidance about either what the evidence was of actually reducing the dose or how to reduce the dose. The guidelines are very vague about the pace at which it should be reduced, and there's not a lot of evidence to suggest, whether it should be 10% once a week or even up to 10% once a month. And then also what kinds of supports are needed in place for people to reduce opioids safely. And however, in response to this guideline and a lot of the opioid epidemic concerns, health systems and insurance providers implemented many policies and practices to reduce opioid prescribing without a lot of evidence to support, certainly with a lot of evidence to support the rationale for prescribing, for reductions in prescribing, but not actually how to do it safely. Okay, let's see. I'm having all kinds of technical problems today here. Let me see if I can get this to advance. Okay, great. So this led to a clinical and policy dilemma in that we know that high doses are associated with overdose. We certainly need to correct some of the mistakes of our profession in the past that was really based on overprescribing and also responsiveness to marketing by pharmaceutical companies. And we know that there's a lot of pressure out there to reduce doses, even among patients who are otherwise very stable. These have been balanced somewhat by the fact that there's a lot of patients with pain who've been organizing against guidelines and their perception that some of these policies are very draconian. There have also been concerns expressed by the Centers for Disease Control and other agencies that the guideline may have been misconstrued and misapplied, that the way physicians responded to it in practice was too strong. And then there's a lot of patients who individually feel like, even though there is an opioid crisis, I personally am not at risk. I'm stable on my dose. I'm benefiting from this dose. And then this has to be balanced by the potential benefits and the potential harms. The potential benefits is, of course, well, we might be able to reduce the risk of overdose if we get people off of opioids. We might have a lot less diversion of opioids to not the person who it was intended to. We might reduce the risk of opioid use disorder. And we know from some data that it actually improves function to come off of opioids and you have fewer side effects. But there's a lot of concerns that this process might be coerced and it actually might be involuntary, and that some patients are actually even being fired from practice as a result of these policies. They may also have increased withdrawal and pain, and therefore increased risk of suicide and increased illicit opioid use, such as fentanyl or heroin use. And then there might be subject to very poor management of a taper without adequate supports or too fast of a taper. So all of these things have to be balanced. There is some evidence that there's some potential harms of discontinuing opioids. Oliva and her colleagues at the VA recently published a study that stopping opioid therapy is actually associated with an increased risk from death, from suicide and overdose events combined in veterans between in the years 2013 and 14. And Coffin from San Francisco did a study in a public health department population that had a high use of heroin at baseline, who found that patients who had their opioid use discontinued actually had more frequent heroin use as a result and more frequent non-prescribed opioid use. Interestingly, they also showed the converse, that if you increase the opioid use, it might lead to more frequent injection. And then finally, there's ecologic data that suggests, of course, that as we stabilize pharmaceutical opioid use and somewhat an overdose, we actually had a surge, of heroin and certainly now fentanyl that's really deeply affected Colorado recently. So I've talked a little bit about why opioid discontinuation might be risky. I'm also going to talk about this concept of opioid dose variability. This is really fluctuations in dose going up and down. And this is really based on some of the prior work that I've done about overdose being relatively frequent after release from prison or after periods of abstinence, which is why sometimes harm reduction principles are very important. There's very high tolerance effects of opioids. And of course, if you've been off of opioids for a while and you resume using opioids, you're at higher risk for having an overdose. And then we know that opioid dose in practice really comes after some negotiation between the provider and the patient about what's the right amount. And this is a dynamic negotiation over perhaps many years of taking opioids. And so there have been concerns about the restrictive policies actually leading for opioid supply reduction, actually leading to more dose variability or more up and down. And this is because if you try to discontinue somebody off of opioids and it doesn't work, they're unable to get off, you might have a compensatory increase in the opioids subsequently because they're having withdrawal symptoms or pain. You might also switch providers who might provide them might provide you a different dose. And then you might need multiple attempts to finally get off of opioids if that's what your goal is. So it could take some time and really to some dose variability. So we were interested in that as a potential risk factor. This is an example of a real, individual's history of opioids over many years, I think 11 years, and you can see it really varies over time. It's not static. There's some periods of discontinuation with an MME that's 0, and there's multiple periods of discontinuations, and then there's some periods where the dose is almost as high as 100 MME on a daily basis. So we basically had a series of research studies that have been published now in 2 publications, and I'll also present a little data that's unpublished, but looking at dose discontinuation and how it's associated with overdose and how it's associated with heroin use as an outcome, and then also dose variability and how it's associated with overdose and heroin use. So these studies were all done in a similar manner. We sort of built these cohorts of patients who were prescribed chronic opioid therapy between 2006 and 2018 at Kaiser Permanente in Colorado. We identified opioid overdoses, and then that was predominantly using ICD codes, but then we also identified heroin use that comes to medical attention. And that basically means people who disclosed that they had used heroin to their providers, or it otherwise came to medical attention because they sought treatment, or they went to the emergency department, or they had a urine tox screen that was positive for heroin metabolites. We took these cases, we matched them to randomly selected controls using risk set sampling. We then looked backwards to look for discontinuation and dose variability from the date that we matched them to the controls. And we then used conditional logistic regression to adjust for potential confounding. So these are our outcomes. I mentioned already fatal and non-fatal overdose using ICD codes, and then heroin use coming to medical attention. We had 4 exposures of interest. We looked at discontinuation for 90 or more days with a dose of 0. We looked at variability. This was assessed by calculating the standard deviation of the daily dose across the patient's follow-up in quintiles. For another one of our aims, we actually looked at 45 days of discontinuation. There's no, clear gold standard definition of discontinuation. And then we looked again at dose variability, but we divided it into basically the median, above and below the median, high and low. So patients in this cohort had a mean age of about 56. They were 60% female. The predominance had a mental health disorder. About a third had a diagnosed substance use disorder. In some cases, probably just on the basis that they were on long-term opioids, they were given that diagnosis. Their doses were largely moderate, between 21 and 50 milligrams morphine a day. And you can see here that the variability divided into quintiles ranged from the standard deviation of the dose, which is the measure of variability, ranged from really 0, very low, to 5, up to more than 27 milligrams morphine equivalents. And about 2% of the people had an overdose during our follow-up time period. 224 of those are pharmaceutical opioids, and 4 of them were due to heroin. All right, so in terms of the findings, we found that in fact, if you could get to a discontinuation, your dose, and it was sustained for more than 90 days, there was a reduction in opioid overdose, predominantly from the effect on pharmaceutical opioids. It's about half. Oops, let's see, let me go back here. The risk. However, if you were exposed to dose variability, there was a substantially increased risk for having an overdose, with a 3-fold higher risk in the highest quintile of dose variability. So people who had a lot of fluctuation in dose had a higher risk of overdose. And that was even when controlled for the absolute dose, which, consistent with other studies we found was associated with an increased risk of overdose. But it wasn't just the increased dose that was associated with overdose. It was also these fluctuating patterns that were associated with increased dose. We also found an association between discontinuation and heroin use. So while it seemed largely protective of pharmaceutical opioid overdose, it did in fact, although it was quite rare, it did have an association with an increased risk of heroin use. And Also, dose variability was associated with an increased risk of heroin use, of subsequent heroin use. So what do these findings mean? They basically mean dose discontinuation is protective in our findings of opioid overdose, largely from pharmaceutical opioids, but dose variability is still a risk factor for opioid overdose and for heroin. Both dose discontinuation and dose variability are risk factors for heroin use that comes to medical attention. And of course, there were lots of limitations to our study design, problems with outcome and exposure misclassification and risk of reverse causation. But we did lots of sensitivity analyses and really tried to employ very rigorous methods to try to prevent those risks. So now, what do these mean for harm reduction in the clinical setting and the management of opioid? And I think this applies both to the clinical setting and to the policy setting in public health. There is no individual, there's no single definition of harm reduction. I'm sure Lisa will present some great ones. I don't think that there's any right or wrong definition, but I'll just give you two examples of what is harm reduction. And I think all of these are useful potentially in this scenario. And actually, I think these are potentially useful for other public health issues, certainly, that we should think about. So harm reduction is really, the Harm Reduction Coalition, which is US-based, says it's a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. And harm reduction is also a movement for social justice built on the belief in and respect for the rights of people who use drugs. Harm Reduction International says its policies, programs, and practices that aim primarily to reduce the adverse health, social, and economic consequences of the use of legal and illegal psychoactive drugs without necessarily reducing drug consumption. And I think that these are all very interesting definitions, and to think about how they might apply to opioid prescribing and our clinical practice around the use of legal psychoactive drugs. There was a very, very nice study done by Dr. Hawk at Pittsburgh, looking at, she basically did a qualitative study where she interviewed patients in a harm reduction oriented HIV clinical setting, where she asked them about what they valued about the specific approaches used in that clinical setting. And these are the principles of harm reduction that she thought were most applicable to healthcare settings. And they are humanism, which is to value, care for, respect, and dignify patients as individuals. Pragmatism, which is that you really can't achieve, that none of us can achieve perfect health behaviors. Certainly I am unable to. And that there's no clear definition of what the perfect health behavior is. Individualism is that every person presents with their own needs and strengths, and that these needs and strengths are what have led them to their decisions and the place that they are now, and that needs to be accounted for. Autonomy is allowing patients to make some of their own choices about medications, treatment, and health behaviors to the best of their abilities, beliefs, resources, and priorities. Incrementalism is that behavior change does not occur immediately. It takes a long time, perhaps many years, and that any positive change is celebrated. And accountability without termination is also very important. In other words, we don't fire our patients because they don't do what we want them to do. They do have to take responsibility for their own health choices and outcomes, but we don't fire them from care. So in terms of what I've learned from these series of studies and its application to harm reduction is that, and also the policy response to sort of some of these restrictive policies around opioid prescribing is that humanism is very important. The patients are organizing against the guidelines, suggesting that it's very important to dignify individuals even during a public health crisis and ensure that their voices are heard when you make decisions that concern them. Incrementalism is also important. This relates to the opioid dose variability. I think it's important not to make very dramatic changes all at once in someone's opioid consumption, even if you're controlling the prescription. Respecting patient autonomy and being pragmatic is important. Dose discontinuation is difficult. It has some risks. It may also have benefits, but it's not going to happen overnight. Patients should have some autonomy, some decision-making power in that, and it should be pragmatically done. And then there's, of course, individualism. We need to think about the fact that there are patients and this is maybe the last point I'll make, that are inclined to discontinue from opioids, that the patients we're inclined, that we want to discontinue from opioids, might be the ones who are at highest risk for having an adverse event like heroin use. And we need to think very carefully about how we apply policies to patients who may be at a higher baseline risk individually. And then finally, of course, terminating patients may actually also increase their risk and lead them to heroin use and other potentially worse outcomes than them taking pharmaceutical opioids. All right, well, I have a big team of people to thank, and I think, are we doing questions at the end?
Yes, we'll do questions at the end.
Okay, great, thanks.
And so thank you so much. And just a reminder to all the attendees, please put questions in the Q&A box, and then we'll have a discussion at the end.
Let me unmute myself. My name is Lisa Rayville. I'm the Executive Director of the Harm Reduction Action Center. We're Colorado's largest public health agency that works specifically with people who inject drugs. Thank you so much, Ingrid, and everybody who is joining us today. I speak quickly. It's kind of my thing. Embrace it, people. Okay, harm reduction reduces the harms associated with X. Today, we're talking in relation to drug use. However, we use lots of forms every day in every way. Sand in a playground, helmets when riding a bicycle, designated drivers, reduces the harms associated with your drunkenness, right? We have prevention over here. We have treatment over here. We have the criminalization of drug users here. I'm just going to talk about the life in the middle. In a very magical world, there'd be no drugs, but we live here, and there's one safe thing that folks can do today. And I think many of us on the call can agree that if stigma, shame, and incarceration worked with drug use, we'd have wrapped this up years ago. All that does is drive use underground, where people have gotten preventable chronic diseases such as HIV, hepatitis C, and died of overdose. So we're doing something different. So harm reduction is, how can I support you for a healthier and safer you today? And quite honestly, there are no bigger health nerds in the world than healthcare providers and people who inject drugs. You guys should really be best friends. So I often talk about the challenges and opportunities of working with people who inject, and harm reduction point blank means we're rooting for you, right? And everybody needs somebody rooting for them. You can meet folks where they're at in the spectrum of change, anywhere from safer use to managed use to abstinence. Abstinence is a friend of harm reduction. It's just not a requirement. We believe if people want to live a life of recovery, they shouldn't have to live with preventable diseases such as HIV and hepatitis C. We believe if people don't want to live a life of recovery, they shouldn't have to live with preventable diseases such as HIV and hepatitis C. Relapse is a part of recovery for so many folks, as you know. And there's a lot of barriers to treatment access. There's virtually nothing for stimulant users. Medicaid still doesn't cover inpatient, so inpatient continues to be a story of hope. There's really mostly social detox and not medical detox, and we can talk about that later if you'd like. Harm reduction is no place for ego. It's a place to forget what you think you know and set aside your opinion so that when you meet people where they're at, you can take the time to ask them where they want to go. Parole and probation's job is saying, you know what you should do, right? That's not harm reduction's job. How can I support you for a healthier and safer you today? Because nobody knows you like you know you. Okay, know your racist drug history. The war on drug users has been incredibly racist and classist since forever, and especially over the last 40 years since the war on drug users was established in the 1970s. It's also when the DEA was established. The Anti-Drug Abuse Act of 1986 put mandatory minimum penalties for drug offenses for folks. Incarceration was never the answer. Then in 95, the crime bill contributes to mass incarceration. Then record amounts of money were allocated to the drug war, and especially the war on drug users. There was some changes in reducing the crack and powder sentencing disparity. However, there still is a ban on syringe exchange funding, a federal ban. And while some states have shifted to medical and recreational marijuana, others have not. And just a couple years ago, the opioid epidemic is declared a national emergency. Now, we could have done a whole PowerPoint just on this, but I only have 20 minutes, people. Okay. There's a common misconception that people who inject don't care about their health. They actually do. Anybody that comes to a syringe access program is being proactive about their health. Anytime you break your skin, you're at risk of infection. One swipe of an alcohol pad can keep folks out of the emergency department for costly skin tissue infections. Syringe access programs are quality healthcare. We also know that people who inject drugs and healthcare providers have a very tumultuous relationship. We know that we can do better on all sides. There's more than 11 million people who inject drugs in the United States. That's an undercount. Stigma and shame have been very clear not to tell anyone unless you're at a syringe access program. 1.4 million people who inject drugs are living with HIV. 5.6 are living with Hep C, and 1.2 million are living with both HIV and hepatitis C, which, let me be very clear, can be completely prevented with access to sterile syringes, cookers, cottons, tourniquets, waters, disposals. So why does somebody inject? No one just wakes up and says, today's the day I'm going to start injecting, and it's going to be magical, right? Dr. Binslinger and I are hanging out, sharing a bag of cocaine. She snorts her half up. I only need a little bit to inject with. She's going to look at me and she's going to say that looks like a bigger, better high, more economical, and to show her how. So we talk about not modeling in front of non-injectors. You don't even get asked. We have black tar heroin in Colorado, which is difficult to snort and expensive to smoke. So you almost have to exclusively inject it. So when we talk about heroin in Colorado, we're specifically talking about people who inject heroin. The average heroin injector injects 3 to 5 times a day. The average meth injector once or twice a day, and the average cocaine injector 12 to 15 times a day. I want to make sure that folks are using new sterile equipment every single time to prevent and eliminate the transmission of HIV and hepatitis C. So seeing someone inject, right? Hearing about the rush and other benefits, feeling like the odd one out, and learning that initially it is more economical to inject versus snorting or smoking. Fun facts about syringe access programs, there's about 14 of us in the state. It reduces injection-related diseases such as HIV and hepatitis C. We talk about necrotizing fasciitis. We talk about osteomyelitis. We talk about endocarditis, Hep B, Hep C, HIV, right? It improves public safety. The state health department tells people to put used syringes in a coffee can, wrap them in duct tape, and put them in the dumpster. Nobody feels good about that. Mine are incinerated. We know that 1/3 of law enforcement officers nationally will be pricked by a syringe at some point in their career. We know that 2/3 of that 1/3 will be pricked multiple times. We've passed 2 pieces of statewide legislation to promote proper syringe disposal. I need folks coming across town with used syringes, but also to reduce needle stick injuries to law enforcement. Before law enforcement pats me down and asks if I have anything sharp, and they always do, and I say yes, and they don't get pricked, I don't get charged. Taxpayer money savings, the average person is living 25 plus years with HIV, which is a manageable and chronic disease, but it doesn't need to be so, right? Needles cost a dime. And evidence-based, there's not many more rigorously tested best practice interventions out there to treat chaotic or non-chaotic drug use as a health issue and not a moral issue. Recently, we did a 2020 healthcare provider survey that surveyed folks from University Hospital and Denver Health primarily, inpatient versus ED in both of them. And it allowed us to kind of figure out our roadmap here for the next year or so on how we can engage healthcare providers and provide more quality healthcare for people who inject drugs. A majority of clinicians do not think that harm reduction practices lead to increased substance use. Cool, thank you. Less than 5% of clinicians at Denver Health and UCH are not interested in implementing harm reduction with patients. I don't like that. 65% of emergency department staff members and 75% of internal staff believe they could develop a substance use disorder under different circumstances. But there were the common barriers, right? They don't know where to send people for harm reduction resources. Hey, it's me over here. They don't have time to discuss harm reduction. Everybody's got 30 seconds to talk about harm reduction, I can assure you. We also do tours when participants aren't here for law enforcement, parole, probation, healthcare providers. So we want to schedule a tour so you can see what a syringe access program is and isn't. So 136 folks didn't know where to send patients to access harm reduction services. Please reach out in your local community to figure out where your syringe access program is. They felt like they needed to prioritize connecting patients to treatment over harm reduction, which I can assure you is probably very frustrating, so we can talk about that. Defer harm reduction conversations to social workers or similar staff. If you're coming in contact with somebody who injects, I want you to tell them about us. And 72 folks felt they didn't have enough time to discuss harm reduction with patients. 30 seconds is all you need. We were really upset to see that 34 clinicians that agreed that people should be put in jail, and 33 clinicians were unsure whether people should be put in jail if they are caught with illicit drugs. This is from the medical community. I need us doing better. Perception that patients who inject can be adversarial, challenging to work with, or don't want to help. I can be supportive. Clinicians' desire to prioritize treatment, which I know that can be frustrating and difficult, especially for stimulant users. Feeling of hopelessness among clinicians because their inability to make a real difference. Talking about an alcohol pad, right? Talking about not licking the end of your needle. That is really helpful for folks. Washing your hands with soap and water, having access to that. You know, talking about how somebody got endocarditis. And then there's a lack of institutionalized process for syringes at the hospital and lack of enough support staff. So I'm really glad that you guys are on today's because we can talk about how we can be supportive. 6 people are not interested in implementing harm reduction with their patients, and 16 are not sure whether they are interested. So I need you to get interested, okay? Dead drug users do not have the opportunity for recovery. When people are alive, there's hope. I currently get more referrals to my program from the Denver Police Department than I do from Denver Health. So we all need to do a little better. All right, data nerds, this one's for you. We've had over 10,000 folks sign up with us. We've done 158,135 syringe access episodes. That's every single time we're engaging with folks and creating a relationship where they can dispose properly of used syringes, get access to sterile syringes and offered referrals. Do you want to talk to staff today about Medicaid enrollment, mental health, substance use, naloxone, health education classes? 75,960 times they said yes. Drugs injected most in the past 30 days were about 50-50 at heroin and meth, and there's a lot of polydrug use. We are working with crack smokers and meth smokers, so much so that we're now giving out pipes. This smoking is risk reduction over injecting, and in a time of COVID, I want to make sure that folks have their access to their own. 72% of our folks identify as male, 30% are housed, meaning their name is on the lease or mortgage. 90% have never been to a syringe access program before. 74% heard about us from a friend. 2% have VA insurance or are part of the VA. For folks that don't have Medicaid or any health insurance, we do have somebody that comes in and signs folks up. 20% of our folks are Hep C positive upon intake. 3% are HIV positive. For the folks that don't know their status, do you want to test today? After reviewing all of the research to date, the senior scientists at the Department of Health and Human Services and I have unanimously agreed that there's conclusive scientific evidence that syringe exchange programs, as part of a comprehensive HIV prevention strategy, are an effective public health intervention that reduces the transmission of HIV and does not encourage the use of illegal drugs. This is Dr. David Satcher. Now, if we were all together, I would have you scream out what year you think it is, and April 1998. Welcome to the late 90s. The number of Coloradans with hepatitis C continues to climb, and I think I know why. All drugs need to be made as blood-like as possible to inject. When folks don't have access to sterile water, it doesn't mean they don't inject. It means use toilet tank water, river water, or saliva. If I'm Hep C positive and I have my injecting water, and Dr. Benswinger has heroin but no water, and I'm really cool, and I let her use my water, that's how she can get hepatitis C. Hepatitis C lives in injecting water for 62 days. So they know not to share the syringes, but the cookers, the cottons, the tourniquets, the water, that can be most difficult. This is the magnification of a needle before use, after 1 use, and after 6 uses, it starts to curve and shred. When you don't have a syringe access program in your community, it doesn't mean that folks aren't injecting, it means they're using that one on the right. So what we're doing is happening in all 35 states and 60 countries. Just want to make sure. Oh, nope, I didn't mean to do that. So it looks a little different. We do the syringe, the drop-in. We have access to service providers right here on site. We have an active people who inject drugs advisory committee, access to mail and phone, especially mail where they can get their IDs. Advocacy, we've passed 7 pieces of statewide legislation in the last 11 years and made 3 Denver city policy changes. We do mobile syringe exchange in high drug traffic areas. We do health education classes and have access to fentanyl testing strips. Folks can test their drugs to see if fentanyl or fentanyl analogs are present before they use, and then they can do something about it. There's a behavior change that can happen. We have a wound care class. That was in particular from folks that said, I want to know when I can definitely take care of it myself and when I absolutely have to go into healthcare providers. We do those referrals, and then we do voter registration. We re-register people who inject drugs, those that are unhoused, and actually if you are, they have changed it, and if you are on parole in the state of Colorado, you can re-register to vote. We want people to be a part of community decisions. And then we do that on-demand HIV, Hep C, chlamydia, and gonorrhea testing. So we try to be as one-stop shop as possible. You say all that, are they a great neighbor? We're an award-winning neighbor, thank you for asking. We're invested in the health and safety of the community in which we serve. The question of enabling, I got into harm reduction to enable people who use drugs to protect themselves and their communities from HIV, hepatitis C, and overdose, to feel like they have someone to talk to, someone who cares, someone who respects them and their humanity, to ask for help and to help others in turn, to find drug treatment and health care, to reconnect with their families, to rebuild their lives, and to take personal responsibility for their health and their futures. That makes me an enabler. I'm proud to claim that term. That was Daniel Raymond out of New York City, and we went a long time not doing anything. We lost a lot of good people. This is drug overdose deaths from 1980 on. A lot of times they only have images from 2000. We've been losing a lot of good people for a really long time. Dead drug users do not have the opportunity for recovery. When people are alive, there's hope. In 2019, we lost almost 72,000 folks to drug overdose deaths in the United States. Of that 72,000, we lost 1,062 in the state of Colorado. Of that 1,062 in the state, we lost 225 in the city and county of Denver. We are already surpassing numbers in 2020. So 2020 will now be Denver and Colorado's deadliest year yet for drug overdoses. We were a top 4 just in the beginning of this year. So I'm gonna go a little quicker because you're smart people. This is our overdose memorial wall. It continues to grow. This is our why, right? But I just want to make sure we get to people living in chaotic drug use tend to be more successful at making positive changes in their lives if they first have their most basic needs met, like food and shelter, access to healthcare, meaningful connection, and being treated with dignity, regardless of whether or not they continue to use drugs, and not contingent on if the difficult circumstances in their lives have changed. People who use drugs are the true first responders in the midst of this overdose crisis. They need to have access to naloxone. And then third parties, people around people at risk of an opioid overdose. So anyone you come in contact with, you should be very supportive for them to carry naloxone to save people's lives. We also know that stimulant overdoses are up in the state of Colorado. Those cocaine, crack, and meth. We need to be having conversations about that. And lastly, I'll just talk about, we are the folks pushing forward to supervised use sites or overdose prevention sites. We want to take injecting out of the public sphere and put it into a controlled environment. It reduces the acquisition of HIV and hepatitis C. It reduces skin tissue infections. It promotes proper disposal. And it's currently happening in 11 countries and over 150 sites. No one's ever died of an overdose at one of these places because there's a trained professional there to recognize and respond. And the same cannot be said for our libraries, our Jimmy John's, our 7-Elevens, and used to just be cops coming up on people overdosing. Now it's 17-year-old baristas. And we have use sites all over town, right? They're just simply not supervised. We've got to do better to chip away at the overdose crisis that we are currently in. It's been very business friendly, as you can imagine. Businesses and hospital campuses were the last unlocked bathrooms in town. This is a physician out of New York City that says we need to play that game where we require politicians to finish every sentence denouncing supervised injection facilities with a phrase. And that is why I think injecting alone in a McDonald's bathroom is better. And this is me. Questions for Dr. Binksfinger or myself?
Oh my goodness. Thank you both. That was amazing. And thank you for the work you are doing. And it is so important. So my name is Emmy Betts. I am an associate professor of emergency medicine, and I'm the deputy director for the program for injury prevention, education, and research. We're very happy to co-sponsor this seminar today with the Department of Epidemiology. So please put, to the audience, please put questions in the Q&A or the chat box. I have a couple to start, and I know we've had one come in already. My first, as moderator privilege, perhaps I want to ask Lisa, for the dose variability, how much is that related to people not having access to constant care? So is it that they're with the same provider who is going like this with their doses, or is that actually a marker that they are in between doctors, getting fired from practices and so forth?
Yeah, I think it could be a combination of both. My guess is that, you know, some of it is because people are trying to discontinue opioids, and so then that results in a decrease. But then I think there also are people who have more unstable sort of life circumstances. Perhaps they, you know, in this particular case, we didn't look at individuals who had lost insurance, but that could certainly be, for example, a reason why you might have some dose variability. Or perhaps you're trying to switch your physician, or you spent a brief time in jail. So there's any number of reasons why that could lead to dose variability. We are actually now doing a chart review study where we're trying to really understand why we see some of these patterns, and look at actually using a risk interval approach to try to analyze some of these patterns. You know, periods where people are going down very quickly, periods of people where people are discontinued, periods where there's fluctuation, and trying to understand really what's going on during those time periods. So we'll know more after that point.
Great, thanks.
But I do think it has, I'll just mention, I do think it has some implications for this COVID time, because of course there's going to be more insurance instability. I think there's probably people who are hoarding medications to some extent, or stockpiling medications, who may also be exposed to dose variability sort of in their own home environments. And then there's likely to be people who have interruptions in their care as a result. So I think, you know, if we do, it seems like we're starting to see increases in overdoses as a result of this. And I wouldn't be surprised if there's some of it that's related to dose variability.
Thank you. And I'm going to get to the two questions the audience has sent in a moment. I do want to jump over to Lisa because Ingrid, you just brought up COVID, and that's what I was thinking about. My God, Lisa, how do you and your organization do this work in the middle of a pandemic and thinking about the additional challenges everyone is facing, but I can imagine it has affected it too. I realize that could be a whole talk in and of itself, but I would love if you could just share any kind of insights or, you know, what it's been like, what it looks like going forward.
I appreciate that. Yeah, you know, we're on the front lines in the midst of an overdose crisis, in the midst of an unprecedented global pandemic, when 76% of our folks are homeless or transitionally housed upon intake. So the social isolation has been incredibly problematic, especially in the beginning. We believe, you know, using alone is one of the risk factors of overdoses. We also had a very difficult, you know, the stay at home if you don't have a home, that's problematic. And washing your hands with soap and water. If you don't have access to running water, that's a problem. The city of Denver did get us a 24/7 hand washing station that we have out front, which has been a true game changer for us. And also unhoused neighbors in the community that aren't a part of our program can also use that. We are pleased that we are an essential service and have not shut down one day during this entire thing. For the first few months, we didn't have any volunteers. That was really tough. So we're like, all right, everybody come back in. You know, our folks always appreciate the factual health information that we give them. In the beginning in particular, it was really tricky because, you know, every day something was changing on social media or in the news. And if you're unhoused, you don't have access to those. So we're really trying to get that factual health information. We have flu shots happening on site. We're doing our very best. People keep asking, when is it going to be over? And it's like, oh my gosh, sweetie, I'm so sorry. I don't know, you know. And then it's also having those vaccination conversations with too. We have a lot of people that aren't supportive of vaccinations for Hep A and B. So this COVID vaccination, we're already trying to talk about that with people. But I think, you know, in particular, staff and participants are really walking through this year with so much grief. The last year and a half, we've been able to name it, and what we're working through is grief from all the preventable overdoses and hanging people on the walls. And now we can't hug about it, and we're having a hard time. So we're just trying to find community with each other. So I can't imagine spending my time with anybody else but my folks. But thank you for asking. It's been
you know, we might have to check in with you both in 6 months. And I was thinking, I was in the ER last night and talking to a patient who's in transitional housing and really trying to get a job and get back out. But there are people with COVID where he's living, and so he can't get jobs because he's been around people with COVID, and like this sort of spiraling, overlapping circles.
Yeah.
Okay, so Ingrid, I think the first audience question was for you from Jackie Denning. Could you talk more about the accountability without termination of the patient-physician relationship, and what does that look like in practice?
Yeah, I also want to make one other COVID comment before, you know, the other thing that I've been seeing in practice that I just thought I'd mention, because I see patients in addiction treatment, and it's not really directly related to harm reduction, but I'm seeing a lot more fentanyl over the last few months, and fentanyl is, I personally, and if anybody has advice for me, I found much more difficult to induce onto buprenorphine patients who are using fentanyl. That's been really difficult. So the standard treatment or approach that we've used for heroin and for pharmaceutical opioids has not been working quite as well, at least anecdotally, in my opinion. And there may be providers who have much better experiences, but it's a lot more difficult. So anyway, unfortunately, all of that is sort of converging. I mean, of course, most of what we see is alcohol related. Alcohol is the major issue right now that I'm seeing in practice, but among the patients who are using opioids, and then I'd say, you know, a small portion of them don't know they're taking fentanyl because they're taking pills like benzos and other things. But then there's another large proportion that is well aware they're taking fentanyl, and that's actually some of them even initiated with fentanyl. So anyway, that's just been my local experience recently, not totally directly related to this, but more related to COVID. In terms of accountability, you know, I think there's just a lot of interim steps that you can take before a patient is sort of fired from the practice. I mean, some patients will, of course, if you tell them you're not refilling opioids, are going to leave you. But I'd say, you know, asking people to say, we had organized a safety clinic at Denver Health, an opioid safety clinic, asking people to attend the opioid safety clinic, learn about naloxone, you know, learn about opioid safety, having them do urine toxicology when indicated, making sure they attend their follow-up visits. Those are all sort of things that you can do for accountability without necessarily resulting in a breach of the relationship. And then I think, you know, there's a lot of incremental steps that you can take. I think similarly to what Lisa was talking about in patients who are prescribed opioids, to try to reduce their risk of an overdose without necessarily discontinuing them from opioids, you know, all of a sudden, such as, you know, asking them to reduce their alcohol intake, asking them to, or discussing alcohol intake, giving them a prescription for naloxone. So anyway, there's just a lot of incremental steps that I think can enhance accountability. And I think it's reasonable to expect some accountability from your patients. So anyway, hopefully that answers the question.
I think so. Thank you. Yeah. Question maybe. So Ingrid, I will say there's a question in the Q&A for you if you want to read it while I ask Lisa a question, and then we'll go to that one next. And this question is a little bit for both of you, but that we have a bunch of providers on the phone, and I know you mentioned Denver Health, Lisa, but I'm curious, do you guys work with any UC Health facilities in any direct way? And or separately, do we know what UC Health, as well as, and not just UC Health, sorry, UC Health VA, as well as Denver Health, which have any kind of harm reduction or referral programs already in place?
No.
Do you have any comments specifically for providers?
Yes, thank you. No. And that's been a problem over the years. I can get cops in here to tour all day, every day. I can do presentations. I cannot get in with healthcare providers. So I take these little opportunities, right, to kind of like spread the good word. But it's really difficult for me to get into emergency departments in particular. That's where they're churning my folks in and out of. So that's why we can't just wait on the social worker to give the referral, because the social worker is not doing it either. So anybody that comes into contact with somebody who injects, I want you to refer to me. And when's the last time anybody's ever said that to you? We've tried in St. Joe's to get it into the, you know, the discharge, you know, we've tried over the years, but it takes people within the systems to chip away at those bureaucratic institutions. As you can imagine, cops don't want to hear about it from me, and healthcare providers don't want to hear it from me. So I really need the support of people inside those institutions to push forward. But no, I have never in 11 years been able to get a really good referral process going. It's been hodgepodgey. And I have to say, I was really disappointed with the 6 people who said they would never do anything with harm reduction. Well, that's incredibly problematic, right? Folks really, thank you, Marion. People really deserve to have a service provider that cares about their health and are experts in what we do, right? There's 14 syringe access programs around the state. There's 3 in Denver. So if you've never referred before, you can be like, hey, I don't know if you ever go to the exchange. I heard this lady talk. She doesn't seem terrible, or however you want to do it. Right? But I really need folks coming here, because when they're going in and out of the healthcare system and not one person is telling them about us, that's a problem.
Thank you. I do know we have UC Health at the main ED. We now have buprenorphine induction for medically assisted treatment. And I assume there's some kind of referral happening afterwards, but I admit I have not been referring people to you, and I will, I promise to try. Ingrid, do you want to comment on programs or referrals in place in the city or among the big systems?
About referrals in the city?
I think the question was, which of the kind of big health systems, so, and I realize you're with Kaiser, have some kind of harm reduction program? I know you work at a substance abuse clinic, but addiction clinic. Do you have other thoughts on sort of what programs are already established?
I mean, I don't know of that many partnerships between healthcare systems and harm reduction, but I think there's a ton of opportunity. I think, some of the types of things that I could see happening as, I think Lisa and I've talked about this before, but access clinics, that are sort of community-based, or access vans, or vans that are, there have been sites where there've been discussions about, I know might sound crazy, but about prescribing, actually about supervised injection within hospitals, because sometimes patients leave the hospital before they're done with their treatment for endocarditis because they want to inject and they can't. So I think that there's a lot of potentially innovative things that could be tested, both from a research perspective, models that could be tried that, might be really interesting, where we could see partnerships. I would love to see healthcare systems actually provide syringes to patients who inject. I think that would be really helpful. So anyway, I think there's a lot more opportunities than we've seen.
Okay, great, thanks. Oh, yes, sorry, Lisa, go ahead.
I was just thinking, thank you, Ingrid, for bringing that up. Is one of the biggest things that our folks have when they're inpatient is they're not kept out of withdrawal. I'm not asking any healthcare provider to get them high, but they certainly need to be kept out of withdrawal, or one of two things is going to happen. They're going to call their friend and have their friend bring them in heroin so they can be well to prioritize their other health needs, or they're going to leave AMA against medical advice and brand it a problem patient. So that's a really big concern. So it's not that people don't want to prioritize their health when they're in there. It's that how many more days do they need to go and be in excruciating pain before they leave, right? Because they are not being treated with, quite honestly, dignity, or being kept out of withdrawal. So that's something that the hospitals really are trying to do a better job with, but we have not seen that. Nobody has a handle on that, quite frankly.
Thank you. Yeah,
and I think that's a legacy of, at least in my training, I was told that 20 milligrams of methadone should deal with patients' withdrawal in the hospital. And so that was sort of the norm when I was in training. I don't know what they're recommending, but now, but I certainly was told that very low doses, and we know that people don't retain in care in methadone treatment usually in general, unless they're on, often above 80. So I think that is an issue where, we probably can improve. I think the successful collaborations have really been around naloxone. I think we've seen a lot more naloxone uptake over time, and that's where healthcare has stepped up, and really, thanks to many efforts, but has really stepped up to try to help.
And I do appreciate that too, but we did have to go around healthcare providers because they weren't prescribing in 2013 and 2014. So we had to go to the legislature in 2015 to ask for standing orders that we didn't need a prescriber on site because we were having so many problems with prescribers, even trying to get a prescription from them to get the naloxone too. So I do have to say the medical community, while it's come a long way, still has ways to go. And we really want to be supportive to that too.
I agree totally. I mean, I can think about even the decade I've been practicing, things are changing, but probably not fast enough. Ingrid, there's a question for you around your the work that you presented and the effect of dose variability. I think you probably have seen the question. So
I'll just briefly mention that, the overdose, we had a cohort, we prospectively followed them for an overdose event. That was then the index date. And then we looked back over the follow-up to look for dose variability. And then the dose itself, the absolute dose, was in the 3 months before the index dose, index date, which is the dose of the overdose. And then those individuals were matched to other people on that who were still on opioids at that date. And the follow-up really started at the time when they were prescribed their third prescription in a 90-day period. So I don't know, hopefully that answers the question. Yeah.
Thank you. And then we'll try to sneak in one more. There's a question in the chat box for you, Ingrid, about your experiences with SAMHSA regulatory changes for treating opioid use disorder during the pandemic. And have the allowances for telehealth and prescribing Suboxone had beneficial effects in your experience or detrimental? So I guess the question kind of around moving to telehealth. Yeah.
Yeah, it's been really very interesting. So we've been, in our treatment program, we have been seeing new patients in person we've been practicing in person throughout the pandemic from the very beginning. We have not stopped. Our goal was really to try to keep people out of the emergency department. So we were considered, while most of Kaiser turned to virtual, we stayed in clinic. But we have been able to do telehealth for follow-ups with patients who are on buprenorphine or Suboxone. And that's been incredibly helpful. And I love seeing patients in their home. It's so much easier for them. We can either do it by phone, we can do it by video. I like the video a lot. I get to get a better context to people's lives. So I actually have really enjoyed that follow-up. And also I do think a little bit of the loosening about urine toxicology and other things has been also extremely helpful. So I think it's been really nice to still have in person. And like I said, some of the inductions have been difficult. So I do believe that for me, it's been really nice to be able to do inductions in person, but having a lot of follow-up by video telehealth has been also fabulous.
That's wonderful. Thank you. So I want to say thank you to both of you for taking your time for presenting today, for a really interesting discussion. We could keep going, I think, for much longer, and I wish we were in person. Thank you for the department, to the Department of Epidemiology for co-sponsoring. I do want to point out our next injury seminar is actually also on related to opioids for people who might be interested. It's going to be December 8th at noon, and it's entitled Protecting the Future, the Lockbox Solution for Opioid Control in a Tribal Community. And that's in partnership with CIAN, the Center for American Indian Health. We'll be sending that out with the link to the recording of this session for people who want to watch it again or share it with others. I'll turn it over to Angela in case she has any last thoughts or thank you she wants to say.
Yeah, sure. Thank you so much for your talk, Dr. Binswanger and Director Rayville. And thank you, Piper, for co-hosting today's seminar. And that's all we have. We are approaching 1 p.m. now. So thank you, everyone, for coming, and see you next time. Take good care.